Hey guys, so today I'll be taking you through periodontal indices. Yes, this slide was made by Dr. Navar Lamdari, Dr. Lal Babu Kamait on the Department of Periodontics, College of Medical Sciences, Nepal. So if this is your first time on my YouTube channel, download this video to your right. You will see a red subscribe button that I would like you to click it just once. Yes, there will be a bell looking icon that will pop up. I'd like you to click it just once as well. Let's go. So in my outline, I have introduction, definitions, classification of index, ideal requirements of an index, objectives and uses of index, oral hygiene and plaque index, gingival and periodontal disease indices, recent advances in periodontal indices, conclusions, and some references. Introduction. Unless you can count it, weigh it, or express it in a quantitative fashion, you have scarcely begun to think about the disease in a scientific fashion. Let's take that again. Unless you can count it, weigh it, or express it in a quantitative fashion, you have scarcely begun to think about the disease in a scientific fashion. Let's go. Definitions. According to Russell AL, an index is defined as a numerical value describing the relative status of the population on a graduated scale with definite upper and lower limits, which is designed to permit and facilitate comparison with other populations classified with the same criteria and the method. Epidemiological studies are attempts to quantitate clinical condition on graduated scale, thereby facilitating comparison among populations examined by the same criteria and method. These are another definition of an index. Ideal requirements of an index. It must be specific, that's specificity, clarity, simplicity, objectivity, validity, reliability, sensitivity, acceptability, and quantifiability. Objectives. For individual patients, recognize an oral problem, effectiveness of present oral hygiene practices. That's if this person is brushing, how effective is their brushing technique, how effective do they brush in the morning or at night, as the case may be. Motivation in preventive and professional care for control and elimination of diseases. In research, determine baseline data before experimental factors are introduced. Measure the effectiveness of specific agents for prevention, control, or treatment of oral conditions. In community, shows prevalence and incidence of a condition. Assess the need of the community, which is very important. Compare the effects of a community program and evaluate the results. Classification of index. Based on the direction in which their scores are fluctuate. Reversible index measures conditions that can be changed. Example, periodontal index. Irreversible index, it measures conditions that will not change. Example, dental caries. Dental caries will not go back. It can only be paused, but cannot be cannot be reversed. But periodontal index can be reversed. Depending upon the extent of which areas of oral cavity are measured. In the full mouth indices, patient's entire periodontium or dentition is measured. Example is oral hygiene index, OHI. Simplified indices measure only a representative sample of the dental apparatus. Example, OHIS. According to the entity which they measure, disease index, D, decay portion of the DMF, that's dental decayed, missing, or field index, is the best example of disease index. So for disease index, we have decayed, missing, or filling due to caries, to be precise. Symptom index, measuring gingival or sulcular bleeding, are essentially examples of symptom indices. Treatment indices, F, that's the field portion of DMFT index, is the best example of treatment index. General indices, Simple index. Index that measures the presence or absence of a condition. Example, plaque index. Cumulative index. Index that measures all the evidence of a condition, past and present. Example, DMF index. DMF measures D for the DMF, that's the decade, measures the present. Missing measures past. Then field also measures past. Indices used for oral hygiene assessment. Oral hygiene index is one of them. Simplified oral hygiene index. Patient hygiene performance. Tureski, Gilmore, Glickman modification of Kuegeli-Heine plaque index. Oral hygiene index, developed in 1960 by John C. Green and Jack R. Vermillion in order to classify and assess oral hygiene status. Simple and sensitive method for assessing group or individual oral hygiene quantitatively. Composed of two components, the Debris index and calculus index. Rules of oral hygiene index. Only fully erupted permanent teeth are scored. Third molars and incompletely erupted teeth are not scored because of the wide variation of heights of clinical crowns. The buccal and lingual debris scores are both taken on the tooth in a segment having the greatest surface area covered by debris. The buccal and lingual calculus scores are both taken on the tooth in a segment having the greatest surface area covered by supragingival and subgingival calculus. Debris index criteria. For this canine, as you can see to the right of this video, no debris or stain present. As you can see from the arrow, that's 1. Soft debris covering not more than 1/3 of the tooth surface or presence of extrinsic stains. For the 3, we have soft debris, other debris regardless of the covering more than 1/3 but not more than 2/3 of the exposed tooth surface. The other one, which is the other lateral, the other central, soft debris covering more than 2/3 of the exposed teeth. Calculus index criteria. Criteria 0, no calculus present. 2, score 2, supragingival calculus covering not more than 1/3 of the exposed tooth surface. For 2, supragingival calculus covering more than 1/3 but not more than 2/3 of the exposed tooth surface, or presence of individual flecks of subgingival calculus around the cervical portion of the tooth, or both. Supragingival calculus covering more than 2/3 the exposed tooth surface, or a continuous heavy band of subgingival calculus around the cervical portion of the tooth, or both. As you can see in the arrow, supragingival calculus, subgingival calculus. Calculation. Debris index is equal to buccal score plus lingual score over number of segments. Calculus index, buccal score plus lingual score over number of segments. Oral hygiene index is equal to DI, that's debris index, plus calculus index. DI and CI range from 0 to 6. Maximum score for all segments can be 36 for debris or calculus. Oral hygiene range from 0 to 12. Higher the oral hygiene, poorer is the oral hygiene of the patient. The higher the oral hygiene index of the patient, the poorer the oral hygiene of the patient. Simplified oral hygiene index, developed by John C. Green and Jack R. Vermillion in 1964 as oral hygiene index, was time-consuming and required more decision-making. Only fully erupted permanent teeth are scored. Natural teeth with full crown restoration and surfaces reduced in height by caries or trauma are not scored. An alternate tooth is then examined if missing. Surfaces and tooth to examine. This is 1 1, that's upper right 1. That's 2 6, that's 3 6, that's 3 1, that's 4 6, and that's 1 6. So the right upper, the central upper and lower right, then the 6 6 on both sides, on the both arches. Substitution, we have for 1 6 we have 1 7 or 1 8. For 1 1 we can use the 2 1, that's the lateral. For 2 6 we can use the 7 or the 8. That's the second premolar or second molar or third molar. For 3 6 we can use the second molar or third molar. For 3 1 we can also use the first premolar. For 4 6, that's the lower left 6, lower left first molar. We can use the second molar or the third molar. Calculation, we have DIS equal to total score or number of surfaces over number of surfaces. For the calculus index, we have total score over number of surfaces. Oral hygiene index simplified is debris index simplified plus calculus index simplified. Interpretation, debris index simplified and calculus index simplified. Good, for good we have from 0 to 0.6. For fair we have 0.7 to 1.8. For poor we have 1.9 to 3.0. For oral simplified oral hygiene index, we have good at 1.2 of upper limit, fair at 1.3 to 3.0, poor to 3.0 to 6.0. Uses, widely used in epidemiological studies of periodontal diseases, useful in evaluation of dental health education programs, evaluating the efficacy of toothbrushes, evaluate an individual's level of oral cleanliness. Patient hygiene performance, that's PHP index, introduced by Charlie AG and Harley JV in 1968. Assessments are based on 6 index teeth. The extent of plaque and debris over a tooth surface was determined. For the first premolar, the buccal surface. For the first anterior, we have the labial surface. For the first premolar on the other side, we have on the upper as well, we have the buccal, the lower molar. Sorry, the 6 is a molar, first molar. So the lower molar on the right, we use the lingual surface. Then 3 1 we use labial, 4 6 we use lingual. Apply a disclosing agent before scoring. Patient is asked to swish for 30 seconds and then expectorate but not rinse. Expectorate but not rinse. Examination is made by using a mouth mirror. Each of the 5 subdivisions is scored for presence of stained debris. 0 is no debris or questionable. 1 is debris definitely present. Debris score for individual teeth and the scores for each of the 5 subdivisions. PHP index for an individual, total score for all the teeth, number of teeth examined. Ratings, scores, excellent is 0, no debris, good is 0.1 to 1.7, fair is 1.8 to 3.4, poor is 3.5 to 5.0. Plaque index, Sealness and low in 1964. Assesses only thickness of plaque at the cervical margin of the tooth closest to the gum. All 4 surfaces are examined: the distal, the mesial, the lingual, the buccal. Scoring criteria: 0 means there is no plaque present. 1. A film of plaque adhering to the free gingival margin, an adjacent area of the tooth. The plaque may be seen in situ only after application of disclosing solution or by using probe on tooth surface. Score 2 means moderate accumulation of soft deposits within the gingival pocket or the tooth and gingival margin, which can be seen with the naked eye. Score 3 means abundance of soft matter within the gingival pocket and or on the tooth and gingival margin. Calculation: plaque index for area 0 to 3 for each surface. Plaque index for a tooth, scores added and then divided by 4. Plaque index for a group of teeth, scores for individual teeth are added and then divided by number of teeth. Plaque index for the individual, indices for each of the teeth are added and then divided by the total number of teeth examined. Plaque index for group, all indices are taken and divided by number of individual. Interpretation: ratings, then score. X0 score 0 means excellent. Score 0.1 to 0.9 means good. Score 1.0 to 1.9 means fair, and score 2.0 to 3 means poor. Uses: reliable technique for evaluating both mechanical anti-plaque procedures and chemical agents. Used in longitudinal studies and clinical trials. Advantage: good validity and reproducibility, can be used as full mouth or simplified. Drawback is subjectivity in estimating plaque. One person can say that this plaque is moderate, and another person will say this plaque is minimal. Turesky-Gilmore-Glickman modification of Quigley-Hain plaque index. Quigley and Hain in 1962 reported a plaque measurement that focused on the gingival third of the tooth surface. Only facial surfaces of the anterior teeth were examined after using basic Fuchsin mouthwash as a disclosing agent. Quigley-Hain plaque index was modified by Turesky, Gilmore, and Glickman in 1970. So we have score of 0 is no plaque, as you can see in the diagram. 1, separate flecks of plaque at the cervical margin of tooth. 2, thin continuous band of plaque up to 1 mm. 3, band of plaque wider than 1 mm but covering less than 1/3 of the crown of the tooth. 4, plaque covering at least 1/3 but less than 2/3 of the crown of the tooth. 5, plaque covering 2/3 of or more of the crown of the tooth. Plaque is assessed on the labial, buccal, and lingual surfaces of all the teeth after using a disclosing agent. The scores of the gingival 1/3 area was also redefined. Provides a comprehensive method for evaluating anti-plaque procedures such as toothbrushing, flossing, as well as chemical anti-plaque agents. The index is based on a numerical score of 0 to 5. O'Leary Index, Plaque Control Record. O'Leary T. Drake R. Naylor in 1972. Method of recording the presence of plaque on individual tooth surfaces. Suitable disclosing solutions such as Bismarck Brown, Diaplaque, or similar is painted on all exposed tooth surfaces. The operator, using an explorer or a tip of a probe, examines each stained tooth surface for soft accumulation at the dentogingival junction. When found, they are recorded by making a dash red color in the appropriate spaces on the record form. Calculation: plaque index is equal to number of plaque containing surfaces over divided by the total number of available surfaces. Since plaque is stained, identification and record making is easy, also aiding patient education. The drawback for this method is records only the presence or absence of plaque. Bleeding point index provides an evaluation of gingival inflammation around each tooth in patient's mouth. Bleeding on probing recorded on distal, facial, mesial, and gingival surface. Calculation: number of bleeding surfaces divided by total number of tooth surfaces times 100. Demonstrates gingival inflammation characterized by gingival bleeding rather than presence of microbial plaque. Gingival and periodontal disease indices. We have the gingival index, the periodontal index, the CPITN, and community periodontal index. The gingival index, developed by Lowe and Silnes in 1963. One of the most widely accepted and used gingival indices assess the severity of gingivitis and its location in 4 possible areas: the mesial, the lingual, the distal, and the facial. Only facial now or buccal, only qualitative changes are assessed. Method: all surfaces of all teeth or selected teeth or selected surface of teeth of all teeth are selected teeth are scored. The selected teeth as the index teeth are the 1-6, the 1-2, the 1-4, the 3-6, the 3-2, and the 4-4. The teeth and gingivae are first dried with a blast of air and or cotton rolls. The tissues are divided into 4 gingival scoring units: distofacial papillae, facial margin, mesiofacial papillae, and entire lingual margin. A blunt periodontal probe is used to assess the bleeding potential of the tissue. Score: absence of inflammation, normal gingivae. Mild, that is for 0. For 1, we have mild inflammation, slight change in color, slight edema, no bleeding on probing. For 2, we have moderate inflammation, moderate glazing, redness, edema, and hypertrophy, bleeding on probing. 3, severe inflammation, marked redness and hypertrophy or ulceration, tendency to spontaneous bleeding. Most times, patients come with the score 2 saying, "I bleed when I brush." Calculation and interpretation. If the scores around each tooth are totaled and divided by the number of surfaces per tooth examined, the gingival index score for the tooth is obtained. Totaling all of the scores per tooth and dividing by the number of teeth examined provides the gingival index score for individual. Interpretation: 0.1 to 1.0 mild gingivitis, 1.1 to 2.0 moderate gingivitis, 2.1 to 3.0 severe gingivitis. Modified gingival index, developed by Lobin, Weatherford, Ross, Lamb, and Meneka in 1986. Assess the prevalence and severity of gingivitis strictly based on non-invasive approach, that is visual examination only without any probing. To obtain modified gingival index, labial and lingual surfaces of the gingival margins and the interdental papillae of all erupted teeth except third molars are examined and scored. At this point, I would like to remind you to subscribe to my YouTube channel if you still have not subscribed by clicking the red subscribe button directly under this video to your right. There is also a bell looking icon that will pop up. I'd like you to click it just once as well. The criteria: 0 score means normal or absence of inflammation. 1 score means mild inflammation, slight change in color, little change in texture, or any portion of the gingival unit. 2 means mild inflammation of the entire gingival unit. 3, moderate inflammation, moderate glazing, redness, edema, and or hypertrophy of the gingival unit. Severe inflammation, marked redness and edema, hypertrophy, spontaneous bleeding, or ulceration of the gingival unit. Russell's Periodontal Index, developed by Russell in 1956. It was only widely used in epidemiological surveys but not used much now because of introduction of new periodontal indices and refinement of criteria. The RPI is reported to be useful among large populations, but it is of limited use for individuals or small groups. Method: all the teeth are examined in this index. Russell chose the scoring values as 0, 1, 2, 4, 6, and 8 in order to relate to the stage of the disease in an epidemiological survey to the clinical conditions observed. The Russell's rule states that when in doubt, assign the lower score. These are field studies and clinical studies radiographic finding. 0 means negative, neither overt inflammation in the investing tissues nor loss of function due to destruction of supporting bone. Score 1 means mild gingivitis, an overt area of inflammation in the free gingiva does not circumscribe the tooth. 2. Gingivitis. Inflammation completely circumscribes the tooth, but there is no apparent break in the epithelial attachment. 4. Used only when radiographs are available. That is, there is early notch-like resorption of the alveolar crest. 6. Gingivitis with pocket formation. The epithelial attachment is broken and there is a pocket. There is no interference with normal masticatory function. The tooth is firm in its socket and has not drifted. There is horizontal bone loss involving the entire alveolar crest up to half of the length of the tooth root. Advanced destruction with loss of masticatory function. The tooth may be loose, may be drifted, may sound dull on percussion with metallic instrument, or may be depressible in its socket. The radiographic finding is that there is advanced bone loss involving more than half of the tooth root, or a definite interbony pocket with widening of periodontal ligament. There may be root resorption or refraction at the apex. Calculation and interpretation. RPI score per person equal to sum of individual scores over number of teeth present. The clinical condition, clinical normally supportive tissue, that's 0 to 0.2, simple gingivitis 0.3 to 0.9, beginning destructive periodontal disease 1.0 to 1.9, established destructive periodontal disease 2.0 to 4.9, terminal disease 5.0 to 8.0. Community Periodontal Index of Treatment Needs, that's CPITN. The Community Periodontal Index of Treatment Needs was introduced by Juka and Namo for Joint Working Committee of the WHO and FDI in 1982. Developed primarily to survey and evaluate periodontal treatment needs rather than determining past and present periodontal status, that is, recession of gingival margin and alveolar bone. Treatment needs implies that the CPITN assesses only those conditions potentially responsive to treatment, but not non-treatable or irreversible conditions. Procedure. The mouth is divided into sextants: 1.7 to 1.4, 1.3 to 2.3, 2.4 to 2.7, 4.7, 4.4, 4.3, 3.3, 3.4, 3.7. The 10 molars are not included except where they are functioning in place of second molars. The treatment need in a sextant is recorded only if there are 2 or more teeth present in a sextant and not indicated for extraction. If only one tooth remains in a sextant, then the tooth is included in the adjoining sextant. Probing depth is recorded either on all the teeth in a sextant or only on a certain index teeth, as recommended by WHO for epidemiological surveys. For adults aged greater than 20 years, 10 index teeth are taken into account: 1716, 1126, 3747, 46, 31, 36, and 37. The molars are examined in pairs and only one score, the highest score, is recorded. For young people up to 19 years, only 6 index teeth are examined: 1611, 2646, 3136. The second molars are excluded at these ages because of the high frequency of false pockets, non-inflammatory tooth eruption associated. When examining children less than 15 years, pockets are not recorded, although probing for bleeding and calculus are carried out as a routine. The CPITN probe, first described by WHO, designed for 2 purposes: measurement of pockets and detection of subgingival calculus. It weighs 5 grams. Working force is 20 to 25 grams. These are the probe. The code, the criteria, the treatment needs. For 0 code, there's healthy periodontium, so the treatment need is 0, no need of treatment. Code 1, bleeding observed during or after probing. The treatment need is 1, and what is advised is self-care. Code 2, calculus or other plaque retentive factors seen or felt during probing. The treatment need is 2, professional care is needed. The code 3, pathological pockets 4 to 5 mm deep, gingival margin situated on black band of the probe. The scaling and root planing is the treatment need. The code 4, pathological pockets 6 mm or more, black bands of the probe not visible. The treatment need is 3, complex therapy by specially trained personnel is needed. Advantage of CPITN: it is simple to use, there's speed in the use, and international uniformity is also there. The limitations: does not record the position of gingivae, doesn't provide assessment of past periodontal breakdown. The Community Periodontal Index, that's the CPI. Based on modification of CPITN, modification is done by including loss of attachment and eliminating treatment needs category. CPI scoring criteria is same as CPITN and done with CPITN-C probe. These are the codes. Code 0 means loss of attachment 0 to 3 mm, CEJ not visible. Code 1, loss of attachment 4 to 5 mm. Code 2, loss of attachment 6 to 8 mm. Code 3, loss of attachment 9 to 11 mm. Code 4, loss of attachment 12 mm or more. Code X, excluded sextant. Code 9, not recorded. Papillary Marginal Attachment Index, PMI. PMA by Shaw and Masley, 1944, to count number of gingival units affected with gingivitis that is correlated with severity of gingival inflammation. The facial surface of gingivae around a tooth divided into 3 units: the papillary gingivae, the marginal gingivae, and the attached gingivae. Usually central incisors to second premolars are examined. The papillary component. The score 0 is normal, no inflammation. Score 1 is mild papillary engorgement, slight increase in size. Code 2, obvious increase in size of gingival papillae, hemorrhage on pressure. Score 3, excessive increase in size with spontaneous hemorrhage. Score 4, necrotic papillae. And score 5, atrophy and loss of papillae through inflammation. The marginal component. Score 0 or code 0, normal, no visible inflammation. 1, engorgement, slight increase in size, no bleeding. 2, obvious engorgement, bleeding upon pressure. 3, swollen collar, spontaneous hemorrhage, beginning infiltration into attached gingivae. Code 4 or score 4, necrotic gingivitis. Code 5, recession of the free marginal gingiva below the CJ due to inflammatory changes. The attached components, when measuring, 0 means normal, pale rose, stippled. 1 means slight engorgement with loss of stippling, change in color may or may not be present. Code 2 means obvious engorgement of attached gingivae with marked increase in redness, pocket formation is present. Code 3, advanced periodontitis, deep pockets evident. The calculation: the PMA index score per person is equal to P plus M plus A. That's all the indices, starting from the attached, the marginal, and the papillary. Uses on clinical trials. It is also used on individual patients and for epidemiological studies. Periodontal Disease Index, that's the PDI. The PDI was first introduced by Bromfield in 1959, composed of three components: plaque component, calculus component, and the gingival component and periodontal component. All the three components will be scored separately using 6 Bromfield selected teeth: the 1-6, the 2-1, the 2-4, the 4-4, the 4-1, and the 3-6. Plaque component. Scoring is done after staining with Bismarck brown solution. Score 0 means no plaque. Score 1, plaque present on some but not all interproximal buccal or lingual surfaces of the tooth. Plaque present on all interproximal buccal and lingual surfaces, but covering less than 1/2 of these surfaces. Score 3, plaque extending over all interproximal buccal and lingual surfaces and covering more than 1/2 of these surfaces. The calculation: plaque score is equal to total scores divided by number of teeth examined. Calculus component, the scoring criteria. Score 0 means no calculus. Score 1, supragingival calculus extending only slightly below the free gingival margin, not more than 1 mm. Supragingival calculus extending only slightly below the free gingival margin. That is the score 1. The score 2, moderate amount of supragingival and subgingival calculus or subgingival calculus alone. Score 3, an abundance of supragingival and subgingival calculus. The calculation is calculus score is equal to total score divided by number of surfaces examined. The gingival and periodontal components. Gingival status is scored first. Gingival status and crevice depth is recorded in relation to CEJ. All areas MDBI, that's mesial, distal, buccal, lingual, is scored. Only fully erupted teeth are scored. There is no substitution for excluded teeth. The score 0 means absence of sign of inflammation. Score 1, mild to moderate inflammatory gingival changes not extending around the tooth. Score 2 is mild to moderately severe gingivitis extending all around the tooth. Score 3, severe gingivitis characterized by marked redness, swelling, tendency to bleed, and ulceration. Score 4, gingival crevice in any of 4 measured areas: the mesial, distal, buccal, and lingual, extending apically to CEJ but no more than 3 mm. Score 5, gingival crevice is in any of the 4 measured areas, extending apically to CEJ between 3 to 6 mm. Score 6, gingival crevice in any of the 4 measured areas, extending apically more than 6 mm from the CEJ. The calculation of PDI score is equal to total number of individual tooth scores divided by number of tooth examined. There are recent advances in periodontal indices. These are the most widely accepted ones. All these indices that I've read for you in the past are the most widely accepted. But for this one, these are the recent advances in the late 90s and the early 90s, mid 90s, and late 90s, as well as early 2000s and the millennials. Basic Periodontal Examination Index, Genetic Susceptibility Index for Periodontal Disease, Periodontal Screening and Recording Index. Basic Periodontal Examination Index, developed by British Society of Periodontology in 1986. Derived from the Community of Periodontal Index of Treatment Needs, that's CPITN. Simple and rapid screening tool that is used to indicate the level of examination needed and to provide basic guidance on treatment need, not a diagnostic tool. The scoring have 0 at no pockets greater than 3 to 3.5 mm, no calculus, overhangs, no bleeding after probing. 1 no pockets greater than 3.5 mm, no calculus, overhangs, but bleeding after probing. Score 2 no pockets greater than 3.5 mm, but supra or subgingival calculus, overhangs. 3 probing depth 3.5 to 5.5 mm, indicating pockets. Probing depth greater than 5.5 mm, black band entirely within the pocket, indicating pocket of 6 mm or more. Guidance or interpretation of BPE scores. 0 means no need for periodontal treatment. 1 oral hygiene instructions. 2 oral hygiene instructions, removal of plaque retentive factors, including all supra and subgingival calculus. Score 3 oral hygiene instructions, root surface debridement or debridement as the case may be. Score 4 oral hygiene instruction, root surface debridement. Assess the need for more complex treatment. Referral to a specialist may be indicated. Genetic susceptibility index for periodontal disease. Genetic markers denote susceptibility towards disease manifestation, and it will be useful to exploit the information hidden into them and to derive a genetic susceptibility index. Single nucleotide polymorphism in genes encoding molecules of the host defense system are assessed, and an association is established between SNP, that's a single nucleotide polymorphisms, and disease status. Periodontal Screening and Recording Index, introduced in 1992 by American Academy of Periodontology and American Dental Association, endorsed by the World Health Organization. Adaptation of the Community Periodontal Index of Treatment Needs, used to measure gingival bleeding upon probing, calculus on a tooth, and periodontal pocket depth in each sextant of the oral cavity. Calculating PSR. Highest score in a sextant is recorded as the PSR score for the sextant. Only one score is recorded for each sextant of the oral cavity. A WHO CPITN PSR probe is used to examine each tooth individually. The advantages of this method: introducing a simplified screening method that met legal dental recording requirements, early detection of periodontal disease, and it serves as an aid in monitoring the periodontal status of patients. The limitations: limited use of the PSR system in children due to inability to differentiate pseudo pockets. Does not measure epithelial attachment. The severity of periodontal disease may be underestimated with its use. This is the assessment and treatment need graph sort of. DPC, that's detailed periodontal chart, used to measure pocket depth. A pocket measuring probe, Williams probe, is used. Main components to record pocket depth: mobility, recession, bleeding on probing, furcation. The mobility: 2 blunt instruments are used to assess a tooth's mobility. Example, end of mirror and probe. To quantify mobility, Miller's index of mobility is used. Grade 0, normal physiological mobility less than 1 mm. Grade 1, movement up to 1 mm in horizontal plane. Grade 2, movement greater than 1 mm in horizontal plane. Grade 3, severe mobility greater than 2 mm on vertical plane. Furcation. The furcation is the point at which the 2 roots divide. A pocket measuring probe is used. Neighbor's probe is used. Ranfield and Ash furcation index. Grade 0, no clinical furcation involved. Grade 1, bone loss up to 1/3 width. Grade 2, bone loss up to 2/3 width. Grade 4, through and through defect. Recession. To measure the recession of an individual tooth, a pocket measuring probe must be used. The probe is placed onto the tooth, and the distance between the cement-enamel junction and the gingival margin is measured. This is the amount of recession that has occurred on that tooth. Before I continue, I'd like to thank you for watching this far, and if you still haven't subscribed, I'd like you to click the red subscribe button directly under this video to your right. Baseline pocket depth. The pocket measuring probe is inserted into the gingival crevice. The distance from the base of the pocket and the gingival margin is measured. In addition, if the site bleeds on probing, circle the score in red, and if the site has suppuration, circle the score in blue or black. Baseline pocket depth plus recession equal to CAL. What happens from the results of the DPC? The DPC allows the operator to find sites in the mouth requiring attention. Sites with pockets greater than 5 mm will require RSD. Subsequent pocket depth and CAL can be measured after treatment to assess the success of the treatment. Conclusion: dental diseases are the most prevalent and most neglected of all the chronic diseases of mankind. One of the major problems in studying dental diseases and the factors in the development of a suitable and practicable method of recording and classifying these diseases and their severity. Dental indices and scoring methods are used in clinical practice and community programs to determine and record the state of health of individuals and groups. These are the references they used. Yes, we have come to the end of this chat and this lecture. I would like you to click the red subscribe button down under this video to your right if you still have not subscribed. My name is Dr. Cherry. I'll see you guys in my next video.